Welcome to Policy Applied, addressing nutrition through produce prescriptions in Medicaid Managed Care. My name is Merlene Tucker, and I'll be running this Dialogue for Health web forum alongside my colleague Jeff Bornstein. Thank you to our partners for today's event, the Center for Health, Law, and Policy Innovation of Harvard Law School, DC Greens, and the Rockefeller Foundation. It is my pleasure to introduce the moderator of today's event, Katie Garfield. Katie is a clinical instructor and director of whole person care at the Center for Health, Law, and Policy Innovation of Harvard Law School. Welcome, Katie.
Thank you so much, Marlene, and a huge thank you to Dialogue for Health for hosting us today. I'm really thrilled to welcome everybody to today's event. I think that many of you already know that the United States is facing an epidemic of diet-related chronic disease. Improper nutrition is in fact the #1 risk factor for morbidity and mortality in the United States, outpacing even tobacco use. In this environment, it's really critical that we identify and scale effective solutions, including programs that provide much needed access to nutritious foods for individuals living with or at risk for chronic illness. And we know that foundational food access programs like SNAP can go a really long way in building a response. But for some individuals, these programs aren't enough. And so as a result, we're now seeing growing interest in a range of nutrition interventions. These include medically tailored meals, medically tailored groceries, and produce prescriptions, just as examples. And these programs tackle this problem head on. While promising, access to these programs has historically been limited, as they often rely on short-term grants and other forms of philanthropic funding. But given the impact that these services can have on health outcomes, and in some cases, healthcare costs, there's a clear opportunity here to improve funding and access to these programs by better integrating them into our healthcare landscape, and especially into health insurance coverage and payment in crucial programs like Medicaid and Medicare. In today's webinar, we're going to take a close look at one of these avenues for funding nutrition interventions, Medicaid Managed Care. To do so, we'll first hear about a new report developed by the Center for Health Law and Policy Innovation and DC Greens, Mainstreaming Produce Prescriptions in Medicaid Managed Care, a toolkit and a policy toolkit and resource library. To kick us off, we will hear remarks from Diana Johnson, manager in the Rockefeller Foundation's Food Initiative, the funder that supported the research for this report. We'll then hear from Kristen Sukis, a consultant for DC Greens, who will take us through a brief overview of the report itself. Then we'll spend the remainder of our time hearing from a panel of experts who are putting this idea into action across the country in states like New York, Massachusetts, and Oregon. So without further ado, let's first hear from Diana.
Hello, everyone. I'm Diana Johnson. I'm with the Rockefeller Foundation's Food Initiative, and we want to thank you for joining us today for this important webinar on the release of a toolkit from our grantees at the Center for Health Law and Policy Innovation at Harvard University. Mainstreaming Produce Prescriptions and Medicaid Managed Care is a report in a series of reports on how to increase access and funding for produce prescriptions in the United States. This is an important part for our Food is Medicine strategy. Food is Medicine for us at the Rockefeller Foundation is the integration of nutrition and food into the U.S. healthcare delivery system. Interventions like produce prescriptions, medically tailored meals, and medically tailored groceries are important interventions that can help improve health and potentially reduce healthcare costs. Today's webinar will focus on produce prescriptions within Medicaid Managed Care. The toolkit describes and provides valuable insight and resources, particularly for how states can design MMC in order to include produce prescriptions. We look forward to you reading this toolkit and digging into this webinar. And I want to give a big thank you to Chilpy and their collaborators at DC Greens for putting this important resource together. On behalf of the Rockefeller Foundation, thank you all for joining us and enjoy the webinar.
Excellent. Thank you so much, Diana. And thank you again to the Rockefeller Foundation for their support for this new report and for their leadership in the field of food as medicine. Next, I'd like to introduce Kristen Sukis, the lead author of Mainstreaming Produce Prescriptions in Medicaid Managed Care. Kristen Sukis is a freelance policy consultant working to boost nutrition security and advance health equity across our food and healthcare systems in the US. She manages DC Green's Food as Medicine portfolio, focusing on increasing access to produce prescription programs in the district. And she also co-facilitates the National Produce Prescription Collaborative State Policy Working Group to equip produce prescription advocates with the education, tools, and resources necessary to successfully advocate for state-level policy change. So Kristen, I'll let you take it away.
Thanks, Katie. DC Greens and Chilpy are excited to debut a new report, Mainstreaming Produce Prescriptions in Medicaid Managed Care, a policy toolkit and resource library. This toolkit is the third report of a series exploring ways to increase access to produce prescriptions in the US healthcare system. Over the next few minutes, I'm going to give you a brief preview of what you can find in this report. To learn more, you can access the full report in the Chilpy website, and I believe Erica has already put it in the chat. Diets low in fruits and vegetables are a leading risk factor for many chronic conditions, such as diabetes, coronary heart disease, and some cancers. These chronic conditions are associated with overwhelming human and economic costs, with more than 2/3 of all deaths caused by at least one of 5 diet-related chronic conditions, and over $1 trillion being spent annually to treat these conditions in the US. Despite this clear connection between diet and health, access to fruits and vegetables remains limited for many populations in the United States. Low-income individuals and communities of color in particular face a disproportionate number of barriers to accessing fruits and vegetables. Next slide, please, Marlene. Thanks. Low-income individuals and communities of color in particular face a disproportionate number of barriers in accessing fruits and vegetables due to structural inequities and systemic racism. And generally, cost continues to be a primary barrier to accessing healthy foods, even for individuals enrolled in federal food assistance programs like SNAP and WIC, which provide resources for food. Next slide, Marlene. Thank you. Produce prescriptions are programs that act as medical treatments or preventative services by providing access to healthy fruits and vegetables for patients with diet-related health risks or conditions who face challenges in accessing nutritious foods. A growing body of evidence shows that produce prescriptions are cost-effective approaches to decreasing food insecurity, boosting fruit and vegetable consumption, and improving health. Research shows direct impacts on biometrics such as HbA1c, BMI, blood pressure, depression, and healthcare utilization. But evaluations also illustrate that these programs have the power to improve patient-provider relationships, decrease the chances of preterm births, and lead to self-reported improvements in overall health management. Next slide. Thanks. Support for produce prescriptions has been steadily growing. Federal legislators have dedicated funds to researching the impact of produce prescriptions through the Gus Schumacher Nutrition Incentive Program, also called GusNIP. And in September 2022, the Biden-Harris administration expanded access to produce prescription programs through its national strategy on hunger, nutrition, and health. However, despite this growing interest and the growing body of evidence, access to produce prescriptions remains limited or non-existent in the healthcare system in many areas across the country. The Mainstreaming Produce Prescription Report Series addresses this issue, exploring policy solutions to increase access to produce prescriptions within the healthcare system. The first report of this series provides a high-level overview of current opportunities to sustain and scale programs across the food and healthcare policy landscapes. The second report builds on this framework by providing policy recommendations addressing 5 core challenges limiting access to these vital programs: funding, research, patient data and privacy, infrastructure, and advancing the field. This report that we're releasing today goes a step further by taking a deep dive into one of the most critical and widely available pathways for supporting produce prescriptions in the US healthcare system, Medicaid Managed Care. In the report, information and guidance is organized into 3 sections. One slide back, please. Information and guidance is organized into 3 sections, each focused on a key step in the process of achieving policy change. Section 1, articulating the problem. Section 2, identifying an appropriate and feasible policy solution. And Section 3, building the capacity of change. I've already covered the problem for you today, that produce prescriptions present a potential response to diet-related disease. But these programs are still unavailable in many areas of the country. I'll now give you a quick overview of sections 2 and 3, which focus on the role of Medicaid managed care as a policy solution, and how stakeholders on the ground can build capacity to change Medicaid managed care policy in their local landscapes. Medicaid is our nation's safety net health insurance program, serving individuals with low incomes. Medicaid operates as a state-federal partnership, with each state designing and administering its own Medicaid program within broad federal guidelines. Over time, state approaches to operating their Medicaid programs have evolved to manage a growing number of enrollees and address concerns such as increasing healthcare utilization, high costs, and poor health outcomes, also known as the triple aim. To address these changes and concerns, states have begun to outsource their Medicaid care delivery and provider payment to private health insurance plans. In this model, in which states contract with private health plans to provide Medicaid services, this is called Medicaid Managed Care. Today, Medicaid Managed Care is the dominant approach states use to deliver Medicaid services across the country. Currently, 40 states and the District of Columbia currently use risk-based Medicaid managed care to administer some portion of their Medicaid program. And 34 states and the District of Columbia now enroll over 75% of their Medicaid beneficiaries in managed care arrangements. Medicaid managed care programs are governed by layers of policy at the federal, state, and health plan levels. To date, the federal government has not explicitly allowed states to cover nutrition interventions under any established mandatory or optional Medicaid benefit category. However, Medicaid managed care systems give states and health plans the flexibility to be innovative, providing ample opportunity to leverage that flexibility to support produce prescription programs. Each state is different. Each managed care system and plan is different. And in just a few minutes during our panel discussion, you'll learn how this plays out. This toolkit breaks down those opportunities at each policy level, providing a roadmap with examples of innovative local solutions for stakeholders looking to navigate these policy pathways. At the federal level, we discuss establishing coverage of produce prescriptions in standard Medicaid benefits and providing guidance and technical assistance to improve the uptake of existing Medicaid managed care pathways. At the state level, we break the opportunities down into 2 categories: state federal opportunities, which include state plan amendments and Medicaid waivers, as well as state plan opportunities, which discuss flexibilities across Medicaid managed care procurement, contracting, and oversight decision-making. Lastly, at the managed care plan level, the report explores leveraging 2 notable discretionary pathways: in lieu of services and value-added services. While articulating the problem and identifying a solution are critical steps, produce prescription stakeholders can also use an array of strategies to set the stage for Medicaid managed care policy change. Section 3 of the toolkit pulls from years spent advocating for produce prescription programs at the local, state, and national levels, and providing tips and tricks spanning building state and local coalitions, identifying opportunities in your local landscape, socializing the issue, building relationships and engaging with decision makers, and celebrating wins. Finally, mainstreaming produce prescriptions in Medicaid managed care recognizes that there are many incredible resources that are available to dig even deeper into each topic presented in the toolkit. The report therefore ends with a detailed resource library, which provide links to additional articles, reports, and online tools that stakeholders can use as they work to increase access to produce prescriptions in their local managed care landscapes. Our health system is in a moment of transition. Policymakers at the federal level are interested in expanding access to nutrition interventions to address food insecurity and high rates of diet-related chronic conditions. Despite this support, access to produce prescriptions remains limited in many areas of the United States, in large part due to a lack of sustainable funding streams. In this environment, broadening produce prescription access through Medicaid managed care not only increases food security and improves health for Medicaid enrollees, but also creates opportunities to expand the evidence base for supporting produce prescriptions, and it improves the readiness of our healthcare system for adoption of a potential future federal produce prescription benefit.
Excellent. Thank you so much, Kristen. That was a great overview. And I hope that our audience members saw that we've provided links to both the full report and the executive summary in the chat. We hope that you'll check out the full report, as there's obviously so much more information and resources provided in the report than we could possibly cover in 1 hour today. But we know from working in this field for a while now that all of these concepts, from produce prescriptions to health insurance coverage to Medicaid managed care, all of it can feel really abstract when we're just hearing about it from the policy perspective. That's why we'd like to devote the remainder of our session today to making this concept as concrete as possible. And so to do that, we're going to have a panel discussion with 4 experts that are doing this work on the ground. As you heard from Kristen, while Medicaid managed care is widespread, it can look very different from state to state. As a reminder, each state administers its own Medicaid program within a broad federal framework. And 41 states currently choose to use Medicaid managed care as part of their Medicaid program. That means that each of these states contracts with managed care organizations to help administer and deliver Medicaid benefits. But as you'll hear from our panel, this can look really differently from state to state. In some cases, states follow a fairly straightforward managed care model, contracting with individual health plans to deliver a defined set of care. In those states, we may see some innovation through the contracting process. For example, using procurement or requirements in a contract itself to incentivize plans to provide access to services like produce prescriptions for their patients. Other states use policies like Medicaid demonstration waivers to create additional funding and flexibility to deliver nutrition supports within a managed care framework. Today, we'll hear from experts operating in states that really fall across this spectrum. First, we'll hear from Kim Prendergast, the Vice President for Social Health for Community Care Cooperative, a federally qualified health center-led accountable care organization based in Massachusetts. In this role, Kim leads the ACO's strategic and policy initiatives addressing social drivers of health, building partnerships across the healthcare and social service sectors. We'll also hear from Hallie Toscher, Manager of Population Health Program Development at Cambridge Health Alliance, where she focuses on developing programmatic solutions to address social drivers of health. We'll also hear from Emily Engel, Director of the Bureau of Social Care and Community Supports at the Office of Health Insurance Programs in the New York State Department of Health. In this role, Emily has the opportunity to foster partnerships between various stakeholders, including healthcare providers and social service organizations, and implement policies prioritizing integrating social care and healthcare. And finally, we'll hear from Carla Vicinich, the Health Equity Program Manager at Adelante Mujeres in Forest Grove, Oregon. In her role, Carla oversees the Produce Prescription Program, which aims to improve health outcomes within the Latina community through nutrition education. It's our hope that by hearing about the varied experiences and models, that our audience members can generate some ideas for similar approaches in their states. So let's go ahead and jump into our panel discussion. Great. So to begin, I'd like to ask each panelist, how is your state using Medicaid managed care and related policies to address patient nutrition? Let's start with Emily. Emily, how is New York State using Medicaid managed care to address patient nutrition?
Thank you. So we, here in New York State have had managed care. It started in 1997 here in New York State under the Medicaid Redesign Team waiver, formerly known as the Partnership 1115 waiver. And in 2014, we passed our New York's Delivery System Reform Incentive Program, as we call DSRIP, because we like to abbreviate everything. And under that waiver, it kind of started this groundwork, right, of collaboration and innovation and focus on population health improvement. And it built the foundation for our value-based payment, which of that required managed care organizations to contract with community-based organizations for the provision of health-related social need interventions. And so we said, hey, per, value-based payment arrangement that you have with your hospitals or independent practice associations, you have to have at least one CBO and one social care intervention per arrangement. And so it really started that bridging and talking and breaking down those silos, all our, value-based payment arrangements that were approved. Food security was a huge focus, no surprise. Housing and food security were our two top focuses. And we had projects like medically tailored meals, nutritional counseling, produce prescriptions, food pharmacies, a mobile food pantry, food pantries located in hospitals, a mobile food pantry, telehealth, transportation, to reach high engage like people with diabetes, so that you could check in with them and provide them the transportation that they need to get food or to get to appointments that are more health related social needs. So it really kind of started us in this direction. It was a great learning experience, and I think we got a lot of good pilots and evaluation from that initial start of value-based payment and using our waiver.
Fantastic. Thank you, Emily. I think that gives sort of a great insight from where New York's coming from in using this idea of value-based payment requirements as a lever to really encourage plans to provide additional services like produce prescriptions. And that's one of the levers we talk about in the toolkit. So a great preview. Next, let's hear on the same question from our panelists from Massachusetts. As you'll see, Massachusetts takes a slightly different approach under its waiver, establishing sort of a new version of managed care entities, which we call accountable care organizations, or ACOs here in the state. And we also have this waiver providing some additional funding for nutrition supports. So let's hear about all of that, starting with Kim.
Thank you so much, Katie, and it's great to be here along with my colleague, Hallie, who's also from Massachusetts. So I will share a little bit. So as Katie mentioned, Massachusetts has a Section 1115 waiver. We are now in our second version of that, but the first 1115 waiver was kicked off in 2018, and it created the accountable care structure for the state. So there were 17 accountable care organizations. A couple of key provisions that were part of that overarching waiver really looked at a different way to provide primary care and required the accountable care organizations to begin to conduct health-related social needs screening, really thinking about the importance of understanding the needs that our members are experiencing, and then gave us a really important funding and framework to be able to respond to those health-related social needs for individuals who had complex physical and behavioral health needs and were high utilizers of the healthcare system. So we're screening universally for health-related social needs, including food insecurity. We see, as we see in the literature, very high rates of food insecurity across the state. The Flexible Services Program invested about $150 million over the 3 years, the 3 final years of the waiver between 2020 and 2022, and asked the accountable care organizations to work with social service organizations in the communities to develop partnerships to provide goods and services in the categories of nutrition sustaining supports and tenancy preservation. So looking at some of the questions in the chat here, we're thinking about both of these needs, recognizing that so many individuals who are have Medicaid as their insurance are not only experiencing food insecurity, but other social needs as well. So we won't talk about that today, but yes, to the question that came in the chat, we are really thinking about the implication of housing instability and homelessness on nutrition needs as well. What this has allowed us to do is partner with nonprofit organizations who had some capacity to build new programs, extend that capacity in the community. So we're not just referring into the food pantries and the meal programs that are funded through grants, but it provided this whole funding stream and the ability for us to think about hiring new staff to serve these individuals and really supporting our members in a very robust way. That has looked like medically tailored meals that are home delivered, medically tailored grocery boxes and meal kits that are home delivered, that is nutrition education, and really providing what we at my organization refer to as food referral coordination, so that someone is contacting the member, bilingual, bicultural individual who can talk to our patients and families about what is their unique experience of food insecurity. Is it because they're not able to cook? Is it because they need nutrition education to be able to use the produce prescriptions that we might be giving them? Is it that they actually need a refrigerator, or they need kitchen items to be able to utilize these items? We find that about 80% of the people that we're working with don't actually have an equipped kitchen to be able to use these services. So we're providing food vouchers for grocery stores, produce prescriptions. And what we're really excited about is that this has allowed us to engage with community organizations that understand the needs of the community. And to another question I saw there in the chat, we're not just working with the big box grocery stores, but investing in those local farmers, investing in organizations to build the capacity in the communities. And I'll turn it to Hallie, who can share a little bit more about what's happening in Massachusetts with her organization and kind of what's to come.
Thanks so much, Kim. Kim talked about the previous waiver, and so that concluded, and MassHealth actually submitted an 1115 demonstration waiver extension request at the end of September of 2022. And that was approved by CMS and actually covers October 2022 through December 2027. And so the current waiver continues the flexible services program and makes some changes to the nutrition programs, such as limiting a member's enrollment in a single nutrition program to a maximum of 6 months, at least for this year. Also make some expansions, like expanding to provide more meals, like 3 meals, 7 days a week for 6 months, which is a change from before, enabling us to pay for kitchen supplies to actually help people make food with the produce that they're purchasing. Also focuses on pregnant people and families by enabling us to actually support the household level for members that are high-risk children or members that are experiencing a high-risk pregnancy. The program will continue in a similar way this year and next year. And then in 2025, MassHealth is actually looking to integrate flexible services more into the managed care framework as part of the health-related social needs services glide path for the waiver that was just approved. And this will actually include transitioning flexible services into more of a fee-for-service framework. So those plans are actually due from MassHealth to CMS this year and next year. So we're curious to see what that actually looks like, but we do anticipate it will continue to require social service organizations to really engage with a healthcare system and have the capacity to be material subcontractors and provide those services. Just briefly, I work at Cambridge Health Alliance, and we partner with a managed care organization at our to make up our accountable care organization. We're a safety net health system and serve a diverse and large number of Medicaid members. And we currently have 3 nutrition programs, and they're each really targeted to meet members' needs and where they're at. So we have medically tailored meals program, home delivered medically tailored grocery program, and a produce prescription program, which has been by far the most successful in terms of the number of people enrolled in the program. So looking forward to sharing more details about that.
Excellent. Thank you, Hallie. Finally, Carla, let's hear from you about Oregon's approach. Oregon, like Massachusetts, uses a demonstration waiver to put a twist on the concept of Medicaid managed care by establishing coordinated care organizations, or CCOs, which take the place of standard Medicaid managed care plans and which have some great flexibilities to address nutrition. So I'd love to hear from Carla about what that experience has been like.
Great. Thank you, Katie, and thank you for having me. So yeah, it was nice to hear from all the other panelists and what other states are doing. So Oregon is very different, and in terms of nutrition, and prior to the 1115 waiver, we had another waiver since 1994, I believe, that was focused on eligibility and prioritized health services and managed care. But it allowed us to become more creative. And so Oregon has a very robust health plan that is funded in part by Medicaid. And we're able to, so Oregon uses Medicaid dollars to match state dollars. And so our Oregon Health Plan, OHP, it started also around the Cover All Oregonians. As Katie had mentioned, I oversee the Produce RX program at Adelante Mujeres in Oregon, and this is focused on the undocumented Latina community. And so this Cover All Oregonians was a insurance that provided individuals from the age all the way up to 26, then a big gap, and then from 65 and older. So again, as Katie said, we use funding distributed through CCOs. And in Oregon, we have 16 CCOs, coordinated care organizations. And they have the flexibility to support newer models and more patient-centered and more focused on reducing these health disparities in that gap that I just mentioned in age. So currently we partner with Care Oregon, and they have been funding our Produce RX program for the last 2 years. This all started with WIC, which we all know about. I set a timer for myself so I wouldn't go over, SNAP and the Double Up Food Bucks. And so now we're really excited about the 1115 waiver because we're seeing how much this is going to change and the expansion and the possibility for our community members when it comes to being food insecure, nutrition, housing, which I saw someone had mentioned before, and then also climate related health challenges. So I ran out of time, but I wanted to just mention we do partner with a local clinic, and they are Virginia Garcia, and so they are the ones who refer us all the patients that we currently have now that we call our participants. We have about 40 that we're funding, and out of those 40, 30 of them are insured by Care Oregon, but 10 of them we were able to use through Care Oregon, so through the CCO, these community benefits for our uninsured participants. So it's pretty amazing. Thank you.
Fantastic. Thank you, Carla. And one theme that I think we've heard across that first question is the way that certain policies like Medicaid demonstration waivers can really create some additional flexibilities within managed care to do innovative things. One thing I did want to underline for our audience is that that's one of the pathways we talk about in the toolkit, the fact that waivers can really be used to expand access to nutrition supports in some amazing ways. And in fact, CMS recently, just this last December, put out a new framework around the use of 1115 waivers specifically to address health-related social needs. I also want to underline for our audience, though, that Medicaid managed care can go beyond demonstration waivers, right? Many states have Medicaid managed care systems that don't necessarily have a demonstration waiver attached to them, but still provide a lot of these same types of opportunities to address nutrition. So to give you some examples of that, so that it's part of our conversation, many states, for example, require screening for health-related social needs within their contracts with their health plans in Medicaid managed care. They may also require referrals for individuals who screen positive. And increasingly, we're also seeing states think about what other provisions that they can build into contracting, what other sort of incentives they can build in through Medicaid managed care to encourage plans to go beyond just screening and referral and think about payment. And a great example of this is the idea of in lieu of services. So this is a managed care policy that's available to all states with managed care, where states can actually approve certain services as cost-effective, medically appropriate substitutes for state plan covered services. And where we're really seeing a big investment there are in states like California, which is really leaning into this in lieu of services concept with their managed care plans to provide the option for plans to cover a whole slew of nutrition services. Also note that in lieu of services has also been used in New York to address nutrition. So I just wanted to first note the important role that you're hearing about waivers in this conversation, but also note that for you audience members who don't have a waiver in your state, that doesn't mean you don't have opportunities to use policy to address nutrition here. Medicaid managed care has a lot of flexibilities built into it already that are described in the toolkit. So now I want to ask another question of our panelists. While each of you come from a state that has seen some great success in integrating nutrition into managed care, we know that the road to get there is not always without speed bumps. So can you give us some insight into one of the biggest challenges you've faced in standing up your program or policy and how you've overcome that challenge? And let's go back to the beginning of our list and start with Emily.
Yeah, so I would say at first it was like the languages between the health systems and managed care organizations and the community-based organizations. There was like this kind of like language gap between the two sides. And then like once we're like, hey, we're all working towards these goals and doing the same work and, you know, let's break down these silos, then it started rolling. And I would say the biggest challenge after that language barrier and differences in maybe, you know, culture would be scale. You know, reaching more members. We didn't require screening here in New York with this last district waiver. And so when you think about things like nutrition, right, you're getting members that are maybe, you know, referred from their primary care, or maybe they're already in the ED or inpatient saying, hey, you know, I'm food insecure. But I think the power of screening is to get people before they're in crisis. And really helping more members that are identifying as food insecure versus, you know, waiting for them to hit the system. So screening, I think, would really help scaling, and it's something we've been talking about here in New York and have a plan for. But I think, you know, that would be one of the biggest challenge right now with our current VBP structure. It's just getting more Medicaid members. We know there's huge food insecurity, especially with the pandemic. And when you look at the numbers of individuals served, it's not where you would think it would be, just based on, you know, the need and pandemic.
Absolutely, and I know that's sort of a big theme, both at the national level and within many states right now, thinking about how do we improve screening and identification of patients. Next, I'll turn to Massachusetts and ask Kim and Hallie what you see as one of your biggest challenges.
So we have served about 11,000 people through our program since we started in 2020. And I think there's sort of two biggest challenges that aren't insurmountable, but that have taken a lot of investment of time and resources. One is, you know, we have really worked to customize these programs with 23 health centers across the state, working with local organizations. We have different programs in different parts of the state to meet those needs. And they're very labor intensive. And I just ran some quick numbers. We've spent about $3 million in services for nutrition. That's, you know, the working with the members and nutrition education. And we've spent about $10 million in goods. That's, you know, provision of vouchers and medically tailored meals and produce prescriptions. But so we've really expanded the capacity of these organizations with which we work, but we're working to support members with immediate needs, and then also giving them nutrition education and helping them navigate the systems to be able to be sufficient after this. And so there's a lot of back and forth, so very time intensive and partnership intensive. So I think it's, you know, very valuable for our members and for our organizations, because we feel good about the ways in which we're doing this work. But it's taken the standing up of, you know, of a team and a lot of individuals who work, which means there's a lot of training and there's a lot of support that's provided. I think the other piece that's a bit of a challenge is the technology systems. With $150 million from the state comes a lot of reporting requirements, and they need to assure that we have the patient privacy protections in place and a system that allows us to capture the information at a very granular level. As a Medicaid organization, we need to report back on what happened to an individual person, as opposed to the way that our partners are used to working, maybe with grant funds and sort of just having some information in aggregate. So it requires a lot of detailed information about specifics that were provided to individuals, enrollees, and the way that we pay those services. So I think the technology side of things has been
excellent. And I agree. I've heard technology as a big theme, and something that is also in some ways a really great opportunity here of sort of building the infrastructure for scaling, as we're talking about the end goal here of being able to sort of scale broadly. It's definitely an upfront challenge, but something that I think can have real reach down the line by building these things now. So Hallie, I'd also like to hear from you about your experience in Massachusetts and sort of the challenges and how you've overcome them.
Yeah, and I'm definitely nodding my head as Kim's talking about technology over here, but I'll talk about kind of two other challenges, one with some overlap to what Kim said. I would say at the beginning, really taking the time to train our staff and our health system to really understand the eligibility criteria and referral form that are required through Mass Health as part of the Flexible Services Program. The staff that help identify and refer members to our program largely deal with social needs, and they're not always comfortable identifying medical conditions for members and filling out the referral form. So that took some time. And we were really able to overcome that by holding regular trainings with teams and working across Cambridge Health Alliance to identify new groups of staff that could help refer members. We work with around 18 or 19 different departments across CHA and our inpatient, psychiatry, emergency department, primary care, and we have some other grant-specific programs. So a lot of different groups working together to help identify and refer members to our programs. But holding those regular trainings with these teams so they felt comfortable actually making the referrals was really important. Another was, some members, just because they were referred and enrolled in the program, weren't necessarily taking advantage of the program all the time. And so we really needed to assess what were the barriers to access. So why are people not actually taking advantage of the program? And I think someone else mentioned transportation before. So we were actually able to partner with Uber last year and provide transportation for members to get to and from the grocery store and market, because we heard from members that was a reason why they weren't necessarily using their prepaid debit card through our produce prescription program. The funding for that has actually changed this year, so we're not able to offer that. So that kind of remains a challenge, but we are still sharing transportation resources with members as well, so they can still take advantage of that to get to the store. But some other barriers to why people may not participate in the program is they don't understand how to use the card. So that requires a lot of administrative capacity on our end to follow up with members, find out why they are not using it, and help them kind of understand how to use their card to get to and from the grocery store. or maybe it's that they're not liking the medically tailored meals, and we need to make some adjustments to that to make sure they really take advantage of the program. So we've been able to drastically increase the number of people who actually use the program once enrolled. So we feel good about some of the steps we've taken to kind of address those gaps.
Absolutely. What I'm really hearing is that, everybody is new to this, right? That the nutrition organizations are new to this, that the plans are new to this, that the state policymakers are new to this. And so it's a learning and sort of iterative process. But that if that sort of communication and engagement continues to happen, there can be real success here. And then lastly, I'd like to hear from Carla about your experience in Oregon from the nutrition organization side. What are some of the challenges that you've faced and how have you overcome them?
Yes, thank you. So we are a very smaller nonprofit organization, and we started this Produce RX program in 2014, so almost a decade ago. Our biggest challenge is, I would say, mixed status families. So how do we help our community members that are undocumented, who are not covered by Medicaid but are in this family? So how do we reach them? So we had to really get creative as well with this with our program, because the majority of the referrals that we receive are children, sadly. So the majority, it's pretty amazing. So how do we get to the mother or the father who is providing the food for this children, or building that, I guess, that community? And the biggest thing, I guess we can all talk about, is sustainable funding. We just started receiving, the last 2 years, we were able to receive funding from the CCO, but for the other 8 years that I just talked about, we didn't have sustainable funding. Every year you're trying to look for someone else who wants to support you. So how do you expand? How do you continue reaching out to the community in need when you don't have that capacity to pay for the funding of this program, but also for us, for our time dedicated? Like I heard from the other panelists, it's amazing to hear how much time it takes to just help one person learn how to use a debit card. It is incredible. It could be days until they finally get to understand that the whole process. But so I think those are things: sustainable funding, and then our mixed status families. And then we try to do other things in Oregon to support, and things just haven't gotten passed through. So lots of campaigns. One, for example, was Food for All Oregonians. So these are struggles that we face that we're trying to address together as an entire state. Thank you.
I think that's so helpful, Carla. I mean, of course, I think that piece about sustainable funding, I think, is so important to raise up here. And I think that's the fundamental challenge that a lot of organizations are facing. And so it's really encouraging to hear that through partnerships with Care Oregon, you've been able to sort of move down a path towards more sustainable funding. I also think what you're bringing out that's really important, and I think we need to acknowledge, right, is that Medicaid Managed Care is part of a much bigger puzzle, right? I think in putting forward this toolkit, what we're trying to do is sort of lift up a pathway to starting to get at some individuals and help them address their nutrition needs. But obviously it's part of a much broader framework and set of programs that should be working together to think about how do we sort of broadly address this issue, whether it's for some individuals through Medicaid Managed Care, for others through SNAP and broader programs or state initiatives. And so I do want to underline that and acknowledge that this is a piece of the puzzle, but sort of I think what every organization finds is that there's obviously so many other pieces to it. And so the opportunities to use this to start moving forward, but also keeping in mind, how do we connect the dots and get at everyone who needs these interventions. So I just wanted to underline that and note that we know that many states are trying to think through what are all the avenues they can use to get at this, with managed care being an important one, but of course not the only one. Next, I'd like to sort of flip that question on its head and really ask, what, as you all look forward, what are you most excited about? What do you see as the key next steps for your organization? And how do you hope to really grow your work in this space? So I'll start again with Emily.
we are actually so excited. We have a pending 1115 waiver with CMS right now. We're in negotiations. It's called our New York Health Equity Reform Waiver Amendment. And this is going to actually create social care networks in each region of the state, because in New York, if you're in New York City, it's very different than upstate, and each region has different needs. And so, you know, again, lessons from value-based payment. You know, we had MCOs contracting with like multiple CBOs, and they were like, this is crazy. Like we just want one contract. And for the CBOs, especially the smaller CBOs, it was very administratively burdensome. So we're creating social care networks in each region. And this lead entity will take care of the fiscal administration and the contracting. We'll have an IT system that coordinates everything. And we'll have approved waiver services through our 1115 waiver, as well as standardized screening for social health-related social care needs. So all Medicaid members will be screened. If someone has a food security issue, we can direct them to the service and community-based organization to then help them with that service, all through an IT platform. And we'll be collecting all this data, the social care data, on a larger platform of our state network. So it's really exciting because we'll have social care data, but also we'll have, you know, kind of these standardized networks that are able to provide things like, you know, the produce services and food pharmacies and your medically tailored meals, and really help a larger spread of Medicaid members. And like I said, in the last challenge, you know, how do we expand and serve more people? Well, by having community-based organizations, the boots on the ground being a doorway, I think we'll be able to get more members and really help a lot of people that have health-related social needs.
Excellent. That's really exciting. And now I'll ask our panelists from Massachusetts, what are you excited about as you look forward?
So much to be excited about. One thing I'm really excited about that I'll just share, operationally, we have started several new programs in this new contract, including a community-supported agriculture investment. So we have 6 months of produce boxes going out twice a month to several members in Cape Cod. Oh, I'm in a room that just the lights went off. And so we're excited about that. Another opportunity to really work locally with an organization, and just some opportunities because we have another 1.5 years with this program to be a little bit more innovative and try a few more things out. I think the thing I'm most excited about is diving a little bit deeper into our data, really thinking about the outcomes. We're seeing improvements in short-term outcomes. Food insecurity is better. Members are saying that they feel like their health is improving because of these programs. We're seeing improvements in diabetes control. We're seeing some improvements in total cost of care and utilization. And so we really want to continue to look at that data so we can identify what are the aspects of this program that we really want to keep and continue into the new version as it moves from this grant program with flexible services in Massachusetts into more of the new version of the waiver, where it's part of our managed care approach. We're excited that this will become the way that we deliver services, because social health is such a key to overall. We can't provide good physical health and behavioral health care if we're not also thinking about the social needs of our members.
Yeah, and building off of that, so I guess I kind of look at it at the program level, more a systemic level. So at the program level, at CHA, we will continue to really try to engage members in nutrition counseling to complement those nutritional goods that they're receiving. We really see that nutritional counseling as a way to help provide more sustainability for these types of short-term programs, since I mentioned it's kind of, at least this year, limited to 6 months of goods. And so that counseling can hopefully last beyond the 6 months of enrollment in the program. Carla also mentioned children. 41% of our ACO are children. And so we're really going to focus on enrolling more pediatric members in these programs as well. And then at a more systemic level, we'll wait for more guidance from the state on how this program will be more embedded into the ACO payment structure. So we're excited to learn more about that. We also have another department at our organization is working on a food security strategic plan that was requested by our Board of Trustees. So we hope that flexible services will be kind of part of that larger food security strategic plan.
Excellent. And Carla, what about in Oregon? What are you excited about?
Also very, very excited. So I think we're just really ready to expand what we have been doing for the last 10 years. Really get to the community members in need. And as I mentioned before, and as she just mentioned, the child nutrition focus. So we're really going to dive into that program that we've already had now for a few years, dedicate more time to nutrition education. So we're giving them these funds, we're giving them the option to buy this local produce, fresh local produce, but what do they do with it? What if they've never seen this before? So nutrition education is a big part for us, and we're going to dedicate a lot more time and energy into that. And then, as I said before, we're really lucky to have Rockefeller funding us this year. So sustainable funding, hopefully they continue to fund us along with CARE Oregon. And then we have something really exciting is that we are opening a fourth pillar at our organization, and it's focused on mental health. And now we're going to connect and how we're going to connect it. We're working on that and incorporate mental health and the direct connection it has with nutrition. So that's really exciting for us at Adelante Mujeres. And then one thing that I did hear, I think Kim had mentioned, is data and the importance of it. We need more research, we need more data. So our organization has invested this year in evaluation and learning how do we really dig deep and understand and prove that this is actually impactful and changing people's lives, not just we're giving them money and they're going to buy fruits and vegetables. So yeah, we're really excited. And then also, of course, our uninsured families. How are we going to get that extra community benefit initiative from our CCO to get more uninsured participants in our program?
That's fantastic. And I hear so many common themes here. And I think that evaluation one that we sort of heard across the board, the data, I think that's really important, because one thing to raise up about the managed care pathways is that by and large, these are optional, right? They're optional to the states, they're optional to plans. These ideas of states can choose to do a waiver. If you don't have a waiver, if you're using other pathways, it may be up to the plans if you want to use in lieu of services, things like that. And so I think that's so critical to hear that all of you are thinking about evaluation and how are we proving the case to really continue to show why this is so necessary and why it makes sense for states and individual plans to be moving in this direction. And so lastly, I know we only have just a minute or two left, so I'm going to do a really fast lightning round. I know many of our audience members may be new to this space and looking for sort of key lessons. So if we could just do one last round robin, if you were going to leave our audience members with one key lesson learned from your experience, what would it be? And I'll start with Emily.
I would say have CBOs at the table while you design the work. They are so important to be at the table. They are the boots on the ground. They're driving these changes and interventions. And so, yes, bring all together your stakeholders and pull from them, but make sure CBOs are at that table too.
Okay, Kim?
Absolutely, to what Emily said. And really thinking about developing these interventions in ways that are meeting the needs of the individual patients in your communities. So, as we think about health equity, it's so important that we're assuring that these programs are meeting the cultural and the language needs, and that we don't see food security interventions as the one size fits all, but we're thinking about who needs produce and who needs education and who needs meals and who needs other kinds of interventions to support their healthy. And I just asked Erica to post, but we have a report on our website, Flexible Services Program, fsp.communitycarecooperative.org, with some examples in case anyone wants that from there to help them think about ways to get started.
Great. And Hallie?
Yeah, I would also say having a broad-based interdisciplinary group for implementation planning was really important for us as we were starting off. Also, making the process as easy as possible for people who are actually meeting, screening, and referring members into the program. And then on the policy side, I think just thinking about sustainability and making these programs sustainable in the future.
And Carla, you get the last word here.
Yeah, I'll be quick. Thank you. No, I think partnerships are super important. I think it's very, very valuable to reach out to everybody in your community who is working on hunger issues already. Ask them questions. Understand Medicaid a little bit better. Who can you talk to that does understand it? And then, of course, communication, because like I said, we had no idea that there was extra money waiting with Medicaid and with Care Oregon. And they actually told us that we were the least funded organization. And if we hadn't had that communication and that meeting to talk about what was going on, we would have never known. We could have funded our uninsured and also increased our funding, monthly funding. So there's just communication and partnerships, I think, are the most valuable.
Well, thank you all. I think we're officially up against time, but that was a fantastic conversation. I so appreciate it. And I'm going to turn it back to Merlene.
We want to thank everybody for joining this web forum. And we do want you to know that the video and the slides will be availavailable by next week at dialogueforhealth.org. Have a wonderful day.